স্যার জাস্ট 10 সেকেন্ড পরে কথা বলা শুরু করলেই হবে স্যার।
আচ্ছা। Good evening, ladies and gentlemen. Welcome you all to this webinar on ECG Basic and Beyond. This is the 20th session of this webinar, ECG Basic and Beyond. In the last two sessions, we learned about the pediatric ECG, about the normal and abnormality of pediatric ECG. Today, we'll learn about more about the pediatric ECG. It will be a case-based discussion. We have got two elegant speakers, Dr. Rezoana Rima, who is the Associate Professor of Paediatric Cardiology, Bangladesh Shishu Hospital, and Dr. Naharuma Aive Hyder Chowdhury, Assistant Professor of Paediatric Cardiology, National Heart Foundation and Research Institute. We have got our course directors, Professor Abdul Wadud Chowdhury and Professor Atahar Ali, sir, with us. We have got our another teacher, international advisor, Dr. Rafique Ahmed, sir, with us. We have got also Professor Jahid Hossain, who is the chairman of the Department of Paediatric Cardiology in BSMMU. Welcoming all to this session. May I request Professor Atahar Ali, sir, to say a few words about this session. Sir, please unmute yourself. Atahar, sir, please.
Qrs.
Yes, sir.
Abdul Wadud Chowdhury.
Atahar bhai, aজকে I am not feeling well. আমাকে একটু করে রাখেন।
Sorry?
I am not feeling.
আপনি একটু অসুস্থ মনে হচ্ছে।
Good evening. Today's session is on the pediatric ECG. Actually, we have already learned that the pediatric ECG is a different specialty. We have already known that we have got two talented speakers today, Dr. Rezoana Rima and Dr. Naharuma. Dr. Rezoana Rima is a very talented, leading academic pediatric cardiologist, interventional pediatric cardiologist, works as Associate Professor of Pediatric Cardiology in Bangladesh Institute of Child Health. She has already established herself as a very popular teacher and interventional cardiologist. This is Rezoana Rima. And thereafter, there will be Dr. Naharuma. She is also very, very academic, talented, popular, leading interventional cardiologist, does lots of interventional works in pediatric fields, works as assistant professor. She is very busy in the National Heart Foundation. So we are very much lucky to have these two talented speakers, that is Rezoana Rima and Naharuma. We are also adult cardiologists, but we are also very much weak, but very much fond of the pediatric cardiology. So we are very much lucky to have these two pediatric cardiologists, that is Rezoana Rima and Dr. Naharuma. So first of all, I request Dr. Rezoana Rima with your presentation. Dr. Rezoana Rima.
Dr. Rima, please unmute yourself.
Thank you, sir. Thank you for your kind words, and thanks for inviting me to present my cases. Whether my slides are visible?
It's not yet coming, but your computer is visible. Your desktop is visible.
Okay.
Yes.
Now?
It's
Yes.
visible now. You can go for slideshow.
Okay.
Yes. You can start now.
My topics is on tachycardia-induced cardiomyopathy in children experienced from Dhaka Shishu Hospital. Tachycardia-induced cardiomyopathy is defined as a kind of cardiomyopathy with cardiac dilatation and dysfunction secondary to sustained or recurrent tachyarrhythmia. Myocardial dysfunction can wholly or partially recover after control of the responsible tachyarrhythmia. Tachycardia-induced cardiomyopathy is reversible acquired cardiomyopathy with generally benign prognosis. It can occur at any age and often proves to be unrecognized by most of the pediatricians in clinical practices. Today, I'm going to present 9 such cases, and these babies are below 1 year of age, so they came early and we could control the tachyarrhythmia. And so before becoming full-blown cardiomyopathy, we could stop the arrhythmia process and improve the LV function. So my first patient is a 2-month-old boy, second issue of non-consanguineous parents, got admitted to our cardiac ICU on 30th January 2016 with the complaints of cough and cold for 3 days and respiratory distress for 1 day. The child was dyspneic, afebrile, pulse was more than 220 beats per minute, which is irregular. Cardiomegaly, basal crepitation, and hepatomegaly was present. This is the baby, and this is the chest X-ray, cardiomegaly. And if you see the ECG, we can see irregular rhythm, varying RR interval, and we can see the multiple P wave before QRS complex. That means some atrial ectopic with varying block, and with some ventricular complex is also there. So this is the baby on the next day, and this ECG is not very good quality ECG, but here you can see the this long RP tachycardia and short PR tachy with variable RR interval. These RR intervals are a bit regular. And after giving injection adenosine up to 450 microgram per kg, the arrhythmia didn't disappear or didn't come down the rate. Then we added injection amiodarone loading dose over 4 hours, then maintenance we have started. And this time we did an echocardiogram which showed ejection fraction of only 46%. So here I would like to have comments. Okay, let me show the full story, then I will want comments from the seniors. After 24 hours administration of amiodarone, patient's heart rate started to drop with varying AV nodal block, but still was irregular. And we checked the cardiac troponin I in the suspicion of viral myocarditis, which was normal. And this is the baby on discharge. We discharged the baby on amiodarone and carvedilol, and after 3 months we could stop the amiodarone. And 5 months later, ECG showed normal sinus rhythm, heart rate 125 beats per minute, and echo showed LVEF is normal, 60%. And after 1 year, we could also stop amiodarone, carvedilol.
আমি ভয় পাচ্ছি
কারো একটা মাইক ইয়ে করা কারো মাইক একটা আনমিউট
other than Dr. Rezoana Rima. Please mute everyone.
So this is the
yes.
So this is the same baby's ECG at 3 years of age. The baby is now 4 years of age and is doing very well without any arrhythmia. So our final diagnosis was spontaneous resolution of atrial ectopic tachycardia. So, sir, do you agree with me, or you whether others have other opinion? Shall I proceed to my next patient, or we will discuss on this?
Rima, you want to discuss this case?
No, I have 9 patients. I just want to know that whether you want to comment on this, or I will go next case.
Sir, I want a comment from Rafique, sir. Sir, is this sinus rhythm?
This one. This
Rafique sir, do you want to?
Okay, this ECG, if you see, look in V1, it's
Right,
basically
yes, sir.
biphasic,
Yeah,
P wave.
yeah.
So either this is sinus rhythm, or if it is a ectopic tachycardia, it is something coming very close to the sinus node. But the heart rate is about, how old is the baby?
Now it's 4 years.
4 years, so that's a little fast for it, but still it's a little tachycardic.
That 3 years, yeah, 3 years of age. Yeah.
Yes, and the other problem is, I think this clearly there is a P wave. I don't see a second P wave. Anyway, the PR is short, but probably for that age it's appropriate, right?
Yeah, that's what we thought, because the ejection fraction and LV dilatation has improved.
The question is
completely improved.
Yeah, after the treatment, right?
Yeah, yes, sir.
I don't think there is a second P wave, because if you look at, can you go back?
This was the, yeah. This ECG is on discharge.
Yeah, I think
or follow up. I think it's 5 months follow up. During follow up, at some point follow up. This one is ECG.
Yeah,
5 months later ECG. Yeah.
Dr. Rafique.
Yes.
Ahmed, I am Professor Zahidi, okay?
Back to previous ECG.
That's heart rate is, you told that I agree with you, that's a bit faster in comparison with to the age of the child. Do you suggest that beta blocker should be continued, or maybe should be with this heart rate?
So we continued carvedilol for 1 year, and after 1 year we gradually stopped.
That's how we just to listen
because
to
the
you.
ejection fraction
But still heart rate will be a bit higher comparison with his age.
Can you go back to the first ECG, please?
This is the first ECG, sir. This is the rhythm strip.
No,
And this one. This is the second ECG, 31st. This one is 30th December ECG, and this is 30th January. This is 31st January ECG. This ECG, this ECG P wave was inverted, and
that's different. Yeah.
2, 3 AVF. This 3 lead, this P wave is inverted, isn't it, sir?
Sure. So I mean, the only issue is that the rate is a little faster, even for that age.
Yeah.
I had one patient who was 29-year-old and heart rate of 130. Initially, we thought it was sinus tachycardia, but then what we found out, it was an ectopic atrial tachycardia coming from right superior pulmonary vein. And if you think of the location of the right superior pulmonary vein, it's sitting exactly behind the sinus node. And the P wave looked perfectly like sinus node. And then we ablated that, and the patient heart rate improved. So 125 is still a little fast on beta blocker for this patient.
Yeah, Dr.
Without beta blocker.
Yeah. I wanted to ask this question: whether patient should be done electrophysiology study to ablate the abnormal origin of the.
The question is ablation. I mean, it's a 4-year-old child. Even in the head.
Now she's 4 years. Yeah.
Yeah.
Now it's 4 years.
4 years. Yeah. Even in the hand of experienced pediatric EP doctor, it is difficult. Number one. Number two, the problem with pediatric, if you do an ablation, let's say we create a lesion of 1 millimeter, and they have looked at pig model, that if the baby pig, they put a scar of 1 millimeter, when they grow up, that scar grows to 1 centimeter.
Yeah.
So that is the problem. So in pediatric, what we should do, we should wait on it. One other drug that can be tried if it is sinus tach without changing blood pressure will be ivabradine. Because ivabradine can lower the heart rate without changing. But this patient is doing well, ejection fraction has improved, we should just follow this patient. But the heart rate is a little fast, even, no question about it.
So, Rafique bhai, I have a question.
Dr. Rafique Ahmed, I do agree with you. What we discussed about, I fully agree with you, Dr. Rafique Ahmed. Okay.
Hafiz?
So I don't know the pediatric literature, but tachycardia-induced cardiomyopathy is defined as prolonged tachycardia, giving the cardiomyopathy, not like episodic tachycardia or one spot tachycardia. Sometimes we see this in the adult that when there is tachycardia, the ejection fraction is read as low because of the interpretation of the echo. But one spot tachycardia is hard to take as cardiomyopathy. And the second, I just wanted to remind the audience that ablation is indicated when there is persistent of the problem and the recurrence of the problem. If any patient, for example, this patient even in the adult equivalent, if this one episode that disappeared and never reappeared, why we cry for ablation?
No, the question was this patient's heart rate is 125, which is a little faster than what you expect for this age. So is it something that, is it an atrial tachycardia that we are missing? That's the question. That was the problem that we are facing with this patient. So I think following this patient, I mean, not going for immediate ablation and following the heart rate.
Okay, sir.
There is some telltale sign of improvement, right? The EF is normalized, patient is asymptomatic, doing okay. And I don't know the original diagnosis, tachycardia-induced cardiomyopathy is correct, because it may be just, there was diagnosis of tachycardia.
We initially thought it may be viral myocarditis associated, maybe viral myocarditis was associated that time, but cardiac enzymes and all are normal.
I think we can proceed to the second case, Rima.
Okay. Okay, sir. So my second patient is a 1.5-month-old baby admitted to our cardiac ICU in April 2018 with cough and fever for 3 days and respiratory distress for 1 day. The baby was weighing 3.4 kilo and was pale and with irregular heartbeat with poor peripheral pulses. ECG showed multifocal atrial tachycardia. I could see 2 different morphology at least with variable block. And ventricular rate was 141. And this is the next day ECG. And so the echo was, there was again severe biventricular dysfunction, EF 31%, and all the chambers are dilated. There was moderate MR. So this patient, we could control the tachycardia with loading amiodarone and with then followed by maintenance amiodarone, and we also added carvedilol. So this is the baby on discharge, and after 1 month, the baby came to our follow-up, and there again atrial ectopic tachycardia with varying RR interval, and QTC was a bit prolonged. So, and the ejection fraction is still 43%. And we stopped amiodarone and we added flecainide. And after 1 month, the baby is on sinus rhythm and ejection fraction improves to 57%. We could stop all the antiarrhythmic drug after 1 year, and her motor development was slow initially, but at present she's achieved all her development milestones and free of any arrhythmia or antiarrhythmic medicine for last 1 year. And ejection fraction has also improved to 69%. So do you want any discussion on this case, or I will go next one?
I think as the 2 cases are similar, you can go for the next one.
Okay. Third patient is a 37 days old baby from Shirajganj, presented with cough and respiratory distress and tachycardia. And here we can see the AV dissociation and LV ejection fraction was mild LV dysfunction. We thought of junctional ectopic tachycardia, and we have digitalized the baby, And we started maintenance digoxin and carvedilol also added. And the patient improved to sinus rhythm.
Rima,
Yes, sir.
the previous ECG.
This one.
Rafique sir?
This ECG, yes, sir.
Sir,
To
Yes.
me, I could see the P wave just after the QRS complex and above the QRS complex, and there is AV dissociation. To me, it's AV dissociation. We thought of whether it is we are dealing with junctional ectopic tachycardia or not, congenital junctional ectopic tachycardia. I don't know whether you agree or not.
Well, can I make a comment on this?
Yes, sir.
Yeah, sure, sir.
If we look at the rhythm strip on the top,
Sir.
it looks like group beating. So
Yes, sir.
you see the, let's start with after a longer interval, the interval keeps changing. And my feeling is that it's probably an atrial tachycardia with Wenckebach AV block rather than junctional tachycardia. Because you see, the P wave is upright in lead 2-3 AVF.
Yes,
If it were a junctional tachycardia, there will be retrograde P wave, which will be negative in lead 2-3 AVF, which it is not in this case. So I think it was probably an atrial tachycardia.
Cardio with varying block.
With Wenckebach block.
Wenckebach block, okay.
Yes, because Wenckebach, you can see the pattern that the RR interval after the pause, first one is long and then gradually gets shorter. That's very typical for Wenckebach.
Okay, sir.
Thank you.
Okay, thank you, sir. So the next patient is a 4.5 months old child presented with inconsolable cry, excessive sweating. And this is the day 1 ECG and this is the day 2 ECG. And here also I found that there is AV dissociation. And in this is a chest lead ECG. And this is the 12, this is not that great. So here also the heart rate is very fast, and there is in lead 2, in lead 3 there is inverted P wave. Lead 3, the P wave is in different position, but it is upright. And lead 1 is also upright. So either a kind of atrial tachycardia or junctional ectopic tachycardia, I'm not sure. So the ejection fraction was 40%. And we started amiodarone loading and then maintenance, and also added flecainide. And after that, the ECG is like this. And on follow-up, LV ejection fraction improves to 58%, but not completely normal. And still the patient is having, still the patient is coming for follow-up. And there is some junctional rhythm still present. I mean, it's not persistently, intermittently. This is the ECG on discharge. So, sir, you want any discussion? This patient, they went to, I think, Madras Medical Mission, India, and they wanted to do ablation, but they said there is a chance of every block, complete heart block, and the child may need and end up with permanent pacemaker. So because of fear of heart block and permanent pacemaker implantation, they refused, and they came back, and they are on, the child is on only medicine, only flecainide. The child is now getting only flecainide. So in any comment or?
Rafique sir, previous ECG, this ECG, no?
This is the first ECG, yeah, day 1, day 2.
Hello, sir. So again, your diagnosis was atrial tachycardia, no?
I thought of junctional ectopic tachycardia because the P wave, there is AV dissociation, that's why. Because P wave is above, I checked the PP interval, and I put the PP interval, and I found the P wave is in this position, and I could see the P wave is just after the Qrs complex and again before the Qrs complex. But this is true that this P wave is not upside down. This is not inverted P wave. Maybe it is a atrial ectopic tachycardia again.
The RR interval is variable.
Variable, yeah.
RR interval is not normal.
Have you followed up any patients that is you have seen in the earlier age, that is before 1 year, but you have followed up to 8 years or 9 years? Is there any recurrence? Is there any express like this, Rima?
Sir, my first patient came to me at 2016. So by that the first patient, the child is now only 4 years. So this is the highest follow-up.
Okay.
In
So,
2020, the child has become 4 years.
So I think this is more inconsistent with the by ECG. It is the atrial tachycardia. Yes, differential
Atrial tachycardia.
right. Like the
Okay,
previous
sir.
ECG. You can proceed to the
Yes,
next
sir.
case.
Okay. This is a 22 days old baby presented with convulsion, excessive sweating, tachypnea, irritability, reduced urine output, and her ejection fraction was also 43%. And we can see the regular narrow complex tachycardia, and we could revert the tachycardia with injection adenosine, and we discharged the baby with digoxin and carvedilol. And after 7 days, echo showed ejection fraction was normal. And this is on discharge ECG. But again, after 18 days, the patient presented to us in the OPD with this, again, SVT. And we asked the parents to admit the child in the hospital to have adenosine, but they disappeared. So, and they lost to follow-up. I don't know what happened to the baby next.
So what was your diagnosis?
Supraventricular narrow complex tachycardia, probably, sir, I don't see any, sir, I was not sure about what kind of tachycardia. I thought accessory pathway mediated, but there is no delta wave or other. Do you? I thought this is accessory pathway mediated, or I don't know.
But adenosine carbureted the tachycardia. Adenosine worked.
Yeah, adenosine worked.
So it was the AV node dependent. That is either AVNRT or AVRT.
Yes, sir.
Dependent. And one tachycardia shows that is the other ECG.
This one.
Yes. Possibly there is a retrograde P wave within the one small square that is within the very close to the RS, that is within the 80 milliseconds. So likely it should be the AVNRT.
Okay. Okay, sir.
If it is in the adult, AVNRT until proven otherwise, right?
Exactly. Do you have any?
But by the way, I just wanted to, because there are some residents and junior doctors. So narrow complex tachycardia does not mean there is no underlying accessory pathway. Orthodox tachycardia can be narrow complex. They can be AV node dependent. It is the antidromic that gives the white complex.
So in adult, also had whether this patient has also reduced ejection fraction, Rima?
Yes, sir, 43%.
So I'm little not, because I'm not familiar with the pediatric literature, but in the adult, we don't call tachycardia-induced cardiomyopathy if we see the EF low on the first identification of the patient. There are several reasons for this. Because of the tachycardia, sometimes we estimate the EF low, and then if there is no changes in the structure of the heart, left atrium, right ventricle, all are normal size, then we don't call that necessarily tachycardia-induced cardiomyopathy, because in the adult population, there is this notion that it has to be a prolonged exposure to tachycardia that gives rise to the lowering of the EF. I don't know about,
yes, sir.
I don't know about the...
Actually, these are all temporary LV dysfunction, not... most of the patient improved their ejection fraction, but not all the patient improved more than 60. Some patient, it is around 55 to 60, like that, 55, 58. So we don't term adequate in a child with ejection fraction unless it is not more than 60. So some patient, it remains as 55, 56, or 59, and most of them improved.
Right. But do you see any changes in the structure of the heart?
Structure means, sir, and in the newborn baby, there will be RV dilatation, and some patient we got all 4 chambers are dilated, and mitral regurgitation, and we don't have the echo loops, so
Yeah. Those patients actually reasonable to call them tachycardia cardiomyopathy.
Yeah, it may not be the tachycardia, but because it takes some months or years to become a tachycardia-induced cardiomyopathy. These are all because these patients came early to us, so with this and we have lot of tachycardia. We have many SVT in the first year of life, but not all the SVT patient develop low ejection fraction. Only those patients who develop low ejection fraction, I have pulled all those cases. But we have many patients came with tachycardia with SVT, but not with LV dysfunction. So I have pulled up only those patients whose who develop LV dysfunction.
So how the pediatric literature defines it? Is it
pediatric literature mostly those patients like 8 years, 10 years, 14 years, and after ablation they improved. Not this early presentation. These patients may be the tachycardia may be present in the fetal life as well. We don't know. So my next patient, shall I proceed?
Yes.
Okay.
Say, this is a 1 month, 5 days old baby presented with respiratory distress. And there is also history of one sibling death at 15 days of age. And ECG showed regular narrow complex tachycardia and inverted P wave in lead 2-3 AVF. And this is looking like long RP tachycardia, and echo showed LV EF 49%. So
your echo was during the tachy or during the sinus rhythm, Rima?
Exactly.
During the tachycardia, sir, and we have echo machine in our ICU, so every day we used to check the echo that whether ejection fraction improves or not. So at least day 1 echo and day 7 echo we have done.
So Hafiz bhai, what is your?
And this is the patient after reversion with amiodarone.
Now your reversion with amiodarone or adenosine?
Amiodarone. This patient, adenosine didn't work. Then with loading amiodarone, we could revert the ECG. We could revert the patient to sinus rhythm, and we discharged the child with oral amiodarone and carvedilol. And echo before discharge was 52%.
That is, so adenosine did not work.
No, adenosine didn't work.
So please, previous ECG.
This is the first rhythm strip.
Yes, this one or after this one? No,
so we started amiodarone, loading dose, then maintenance, and during maintenance at some point it reverted. A gradual ECG, sir.
Rafique, sir.
Yes.
To see this one.
Sorry, I missed the part of it. What was the ejection fraction?
49%.
Yeah. I mean, one of the concerns I have with amiodarone is the experience, amiodarone causes irreversible damage to many organs.
Yes, sir.
So, I mean, sometimes
we used to check, sir.
Yeah.
Yes, sir.
Sometimes we are forced to use amiodarone. I think one of the things that I'm not saying that we should not use amiodarone, but our threshold for amiodarone use should be high, especially in pediatric patients, because
yes, sir.
Liver function test abnormality can reverse, but if the thyroid function goes, that's an irreversible process, especially in a growing child.
Yes, sir.
So like ejection fraction 49%, and of course we cannot try drugs like flecainide because there is a problem with other choice in Bangladesh. Yeah, sotalol may be a choice. Yeah. sotalol, but sotalol, there is no intravenous preparation, unfortunately.
Yeah. Yes. Sir.
So if the ejection fraction is over 40%, maybe it's not a bad idea to see if we can try sotalol. Of course, amiodarone intravenous preparation. The other problem is that once we use amiodarone, we cannot say we'll use amio IV and then switch to sotalol. That doesn't work well because that's a problem. So it's a difficult situation. So you have to keep an eye and minimize the duration of amiodarone use. I mean, one of the choice, this patient, it converted and with amio.
Yes, sir.
Maybe it was an option that let's do this. Let's keep the patient on beta blocker only. Send the patient home. Or after a few days of stopping amiodarone, give PO sotalol under supervision. So, I mean, these are the options. There is no right or wrong answer. So please keep that in mind with amiodarone.
Yeah, we check liver function and thyroid when the child is on amiodarone, and we don't put the child on amiodarone for a long time. We usually give a loading dose, then start minimum maintenance dose. We give for like 5 milligram per kg over 4 hours loading, then 5 to 15 microgram per kg per minute, and we at the same time we started oral amiodarone 8 hourly, then we come down after 1 week to 12 hourly, then after 1 week daily. Like that we used to we always try to come down and stop amiodarone as early as possible, and at the same time we used to check
how much
liver function.
Amiodarone are you giving?
Rima, your previous rhythms to ECG, Rima.
No. How much? What is
our maintenance dose is 5 to 15 microgram per kg per minute IV. Oral dose is 4 milligram per kg per dose 8 hourly first week, 4 milligram per kg per dose 12 hourly second week, 4 milligram per kg per day daily. Then we gradually stopped.
Yeah. Okay.
Rima, your previous rhythms to ECG.
This one.
Rhythms to ECG.
Yeah. This one, sir.
No. This one. Sir, Rupik sir. Sir, this ECG and the third ECG, just this patient has got that is adenosine did not work, terminated by the amiodarone. Sir, about this ECG, just diagnosis, sir, is there any association between P-wave and Qrs complex in this ECG?
Is it PJRT, or at some point I thought whether it is a PJRT or not?
Well, if it is paroxysmal junctional tachycardia, then there will be retrograde conduction. So I have to look at it carefully and look at the intervals, because one thing is true, that the RR interval is regular, but the P2P interval is variable. So if you look at in the middle of the strip, you will see there is P2P interval is longer than R to R interval.
Right, sir.
So that means that tachycardia is independent of the P wave.
Right, sir.
So that's an interesting finding. And this one more likely can be a junctional tachycardia because there is retrograde block probably.
Sir,
so
third ECG may help, sir. Rima, third ECG, your third ECG, next one.
This one.
Next one. Yes, sir, this one.
Yes, so this one, of course, you can see the retrograde clearly, a one-to-one retrograde conduction. So it'll be nice if you could kindly send me this ECG. That will be great. It's a good collection.
Okay, sure, sir.
Sir, if any comments regarding the tall P wave here?
Well, tall P wave, the problem is that when you have junctional tachycardia, the P wave will go backward in the middle of the heart. So in V1, it will be a very tall positive P wave. So height-wise, we cannot make any comment on this. That height of P wave that we use will be only applicable when it is a sinus rhythm, because other ones we have no standard for this.
Thank you, sir.
My other question is that did you ever try calcium channel blocker for this patient?
Exactly. That's what I was asking.
Verapamil.
Yes.
And no intravenous diltiazem.
No, we don't.
Not available,
We
sir.
don't have available diltiazem.
Sir, one.
And below 2 years, we don't use any verapamil.
Why not?
Because we don't know whether we are dealing with accessory pathway mediated tachycardia or not sometimes. So our protocol is to give first adenosine adequate dose up to 500 microgram. If it doesn't work, we most of the cases we give amiodarone loading dose. With that, most of the patient reverted. And we are very cautious about amiodarone, and we gradually taper and off. And we usually continued with carvedilol or beta blocker like carvedilol because there is LV dysfunction at the same time. So that's why we continue we continue carvedilol for a long time, but we stop amiodarone after some point. After the child is maintaining sinus rhythm for like 1 to 3 months, then we stop.
Yeah. I mean, I would like you to consider two things. One, rethink about amiodarone. You see, we all talk about algorithm. If you look at even American College of Cardiology, each year the algorithm changes, every few years changes. So what is good for us today may not be good tomorrow. So please think about that. One, whether we can use anything else. Second is, for tachycardia, metoprolol is better than carvedilol. And of course, the question is, this patient has cardiomyopathy, then you can consider metoprolol succinate, because metoprolol has more effect on the AV node than little beta blocker. So that's one consideration. Please keep it in mind. And I think my main concern with amiodarone is that the day you will find thyroid dysfunction, that thyroid is gone. That is the problem. If you find liver dysfunction, it will reverse. If you have pulmonary problem, that will reverse. The other problem is that there is a small incidence of pulmonary pneumonitis, which literally can kill the patient. So if you think about verapamil or diltiazem, this has been in use for more than 30, 40 years. There is no terrible side effect of this. So if I'm taking a risk, I would rather take risk with calcium channel blocker than amiodarone. So keep that in mind, and you have to experiment with these things. I mean, one of the things is that yes, a book says this, we have found good result with this, and from time to time we have to experiment with newer thinking process, and not for all patients. See what happens if we get a better result. That may give us more. But these are good cases, fantastic cases.
Rafique bhai,
there is an injectable form of
amiodarone-related acute problem is extremely rare. Amiodarone-related acute problem is amiodarone lung, that the pneumonitis and can be really hypoxia. But this is really very rare. And all problems with amiodarone is long-term accumulation toxicity. And pulmonary fibrosis can be a problem, and accumulated toxicity with pulmonary, at least in the adults, is not an easy thing and may not be reversible, but cumulative toxicity is the one. But acutely, amiodarone, as we may be afraid, but the toxicity actually is rare. I don't know the literature
let me comment on that. Hafiz, you are post-amiodarone period child. We are actually amiodarone period child because we used to use a lot of amiodarone. And the deaths from amiodarone has happened with pulmonary toxicity. And that you cannot save the patient by any means. So the reason you think that it is not common, because the time that you are looking at, by the time amiodarone uses have gone down. In the late 80s, early 90s, there is really big time use of amiodarone, and that was terrible. We have seen patients dying from amiodarone toxicity. Please don't forget that.
Yeah, I'm telling you the current literature anyway.
Well, current literature is because we don't use it anymore as much. But these are children. You have to understand, giving amiodarone to a child and an adult is different. So I'm not saying that we should not use it. I'm not saying, but I'm just saying that we have to be careful with this drug. It is a dangerous drug.
Rafique sir.
I have a
Hello.
comment, sir.
Hello.
Rapid heart rate during echo, there is a give false impression of LV dysfunction or RV dysfunction. Is there any
Absolutely, absolutely right. This is other problem. Like I had a patient the other day. Patient was in atrial flutter, ejection fraction was 45%. And then once the rate controlled, next day EF became normal. So it is not a normalization of EF. Basically, it was tachycardia that made it difficult to assess the LV function, and it was artificially low. Thank you.
That's exactly I was saying. This is not tachycardia-induced cardiomyopathy.
Rafique sir.
Exactly.
Assalamu alaikum.
Sir, we are running short of time. We have got
Just a few comments.
Next one.
I think we can
Dr. Abdul Salam
get to the next session of Dr. Naharuma.
Okay.
Next one.
We hope you recover very soon and stay with us. Yes, I'm giving you the floor, sir. Dr. Rima, thank you very much for your brilliant presentation and excellent.
I have not. Okay, it's not completed.
Okay, but we have.
This is the same patient. That same patient lost to follow up and stop all medicine and came after 1 year with this ECG again.
Dr. Firoz.
Yes, sir.
আমি একটু কমেন্টস করতে
And this time
ব্যাক মিনিট যদি দেন
স্যার ও শেষ করে নিক কথাটা
আচ্ছা
রিমা প্লিজ
আচ্ছা
ফিরোজ
so
রিমা তিনটা কেস পর দেখাই নিক নয়টা কেস তো দেখাই নিক তারপরে
আচ্ছা ঠিক আছে so this patient at last when the patient came after 1 year and he stopped all the medicine and there is still again AV dissociation, so we have given this time digoxin, not digoxin, beta blocker, and with beta blocker the heart rate has come down but the rhythm is not regular and the child has having some motor developmental delay. And this is the 18 days old baby delivered at 35 weeks gestation due to fetal tachycardia, presented with respiratory distress and irritability since birth and history of convulsion 2 times. We can see regular short narrow complex tachycardia and we reverted this patient with digoxin and we discharged the baby with digoxin and beta blocker, carvedilol, and 2 weeks later, again the child developed atrial ectopic tachycardia, and we stopped digoxin and we added flecainide. And this is the baby on follow-up at 1 month, 19 days of age. So I don't know whether still there is 2:1. Yeah, that's what. But ejection fraction improved. And the next baby is 8 months, 15 days old child, presented with excessive crying, restlessness for 15 days. History of similar illness intermittently since 1 month of age. And the ECG was whether SVT with aberrancy or ventricular tachycardia, we were not sure. This was the ECG done outside. And injection adenosine given, there's no improvement. Injection amiodarone loading, then maintenance given. Heart rate came down. Next day again, the child developed SVT. We have given magnesium sulfate, propranolol added, not improved. DC cardioversion done, given 3 times. And that wide complex tachycardia converted to narrow complex. And we continued amiodarone drip with 5 microgram per kg per minute, and echo showed there was rhabdomyoma with severe LV dysfunction. Ejection fraction was 40%. And gradually, with amiodarone drip, the heart rate came down to this. On discharge, the ECG is like this. Same in sinus rhythm. And the last patient is a fetus. It's a 32 years old school teacher referred from Chittagong at 30 weeks of pregnancy due to fetal tachycardia. The mother has gestational diabetes mellitus on insulin, normotensive. There is a previous history of one neonatal death 1 hour after birth, delivered at 34 weeks with same fetal tachycardia with hydrops 2 years back. Her weight was 77.5 kilo, pulse was 106 beat per minute, blood pressure normal. And fetal echo showed structurally normal heart with mild signs of hydrops fetalis. We checked mother's thyroid function, electrolytes, calcium, magnesium, and baseline parameter. And this is the fetal echo. You can see the tachycardia and mild ascites and mild pericardial effusion. Heart rate was 270 beat per minute. And you can see that these are the atrial contraction we can see. So atrial rates are fast, this we could appreciate, but ventricular rate, it's not well understood. And we have digitalized the mother with oral digoxin, 500 micrograms, 6 hours apart, 2 dose, then maintenance dose of 250 microgram, 12 hourly, started 12 hours later. And after 1 day, mother pulse was 104 beat per minute. There was no complex, but fetal heart rate is still 232. Then we wait for 2 days. We added sotalol, 160 milligram BD. 2 days later, mother complains of dyspnea, occasional breathing difficulty, and fetal heart rate still 230 beat per minute. So as there is no change of fetal heart rate and mother could not tolerate sotalol, we omitted sotalol and we increased digoxin to 250 microgram 3 times daily, and we added flecainide 200 milligram BD. We checked maternal electrolytes, calcium, magnesium, which are normal, and 12-week ECG show PR is a bit prolonged 204. And 2 days later, fetal heart echo showed fetal heart rate came down to 172, 177, no ascites and minimal pericardial effusion. You can see the fetal heart rate 172. And finally, after 2 weeks, that is on 32 weeks of gestation, fetal heart rate could come down to 157 and there was no ascites and pericardial effusion. The pregnancy was continued till 37 weeks and reduced the digoxin dose to 250 microgram once daily, along with flecainide 200 milligram 2 times daily till the morning of the LUCS. And this is after reversion. So now the fetal heart rate has come down to 140. Then a male baby born of 3.4 kg. The child cried immediately after birth, and the baby's reflex activities were moderate, mildly dyspneic. Saturation was 95%, and heart rate was 150 beat per minute. We checked the ECG, and we found there was atrial tachycardia, atrial ectopic tachycardia with varying block. We started maintenance dose digoxin, but the tachycardia persisted. Then propranolol was added and digoxin omitted, and baby was discharged with propranolol TDS. At 1 month follow-up, baby was in sinus rhythm with heart rate 100 beat per minute. Propranolol tapered to BD dose and discontinued after 2 months. At 6 months follow-up, baby was in sinus rhythm, echo showed closed ductus, and ejection fraction was 59%. And this is the ECG at 1 month follow-up, at 10 days, and 1 month follow-up ECG. This is the baby at 6 months of age. So to conclude, tachycardia-induced cardiomyopathy is children incurable and the diagnosis is quite difficult. Pediatricians and family doctors should try to look for specific signs of cardiac insufficiency or arrhythmia. Pediatric cardiologists should search a tachycardia-induced cardiomyopathy in every idiopathic form of cardiomyopathy. Thank you, sir.
Thank you, Dr. Rima. It was really a good one, very good lecture. In fact, I don't know how many of the adult cardiologists have dealt this sort of things. You have done a great job doing a great job with these things. Atahar sir, you have got any comment?
No, actually, but this is a great, wonderful, extraordinary. I did not know actually that they did that. They treat the that is fetal baby like this. Really, this is a wonderful, really extraordinary work. I must congratulate Rima.
Thank you, sir.
I want to hear such a case many more. We have got a short of time, otherwise it's extraordinary. I think there are many of our faculties who want to discuss this, but we have got the short of time. Firoz,
Yes, sir.
we just like to thank Rima. You just you please stay with us. We just want to hear from the Naharuma. Firoz.
Yes, sir.
I will stop share.
So now may I request Dr. Naharuma to start her presentation.
Sir, is the slide is visible?
Yes, visible. You can go for slideshow.
Okay.
Okay.
Thank you. Thank you for the extraordinary presentation, Rimapa, and hope that you will recover early. And before starting off I'm Dr. Naharuma Chowdhury, working in National Heart Foundation as an assistant professor in Paediatric Cardiology department. And before starting my presentation, I want to show my heartfelt gratitude to the organizing committee of the ECG group, because they not only acknowledge the pediatric ECG, but also acknowledge the pediatric population, that it is not a miniature of the adult population. This has an extra identical specialty. So today I'm going to some case-based discussion in ECG in congenital heart disease. And it is an insensitive tool for diagnosis of congenital heart disease and reflect the hemodynamics and clue to diagnosis. And understanding the underlying physiology is important, because a normal the ECG with right axis deviation RVH can present in normal child in a neonate, and also can present with in case of tetralogy or can present with RVH. So we have to correlate clinically with the ECG finding. So it also helps the cross-check of the echo. Sometimes there is some mismatch with AV discordance or corrected TGA, where the ECG can give us a clue by seeing some points. We can tell the echocardiographer that please cross-check, we are finding this case, maybe something has missed. So Jamil sir has nicely elaborately touched the each segment of the ECG in previous session. I just used that things and some extra things that we have do in sequential approach to a congenital ECG. If we see, initially we see the normal position of the situs and how to determine this situs. Situs means in right atrium in right side and left atrium in left side, and there is visceroatrial situs. And this is situs inversus, where the right atrium goes to the left side and left atrium comes to the right side. This is the mirror image. And how to confirm this situs? If we check, the sinus node is located in the SVC right atrial junction, and the impulse goes towards the AV node. So we will get the positive wave in lead 1. And it is away from the AVR, so we will get negative point in the AVR. So this sinus P wave helps us to determine the visceroatrial situs. And the normal situs that I mentioned, that P wave will be in left lower quadrant. That means positive in lead 1 and 2 and negative in AVR. So these things denotes the situs soletus. And how to determine the situs inversus? Now this right atrium goes towards left and left atrium towards right. And now the impulse is coming from the left shoulder towards the AV node. So we will get negative pulse, negative P in lead 1 and positive in AVR. It is seen here that negative in lead 1, positive in AVR. So that right atrium is in left side. This also can be present in ectopic rhythm from the left atrium. So this way we can determine the situs. And next situs, how to determine the cardiac position in the thorax. We know that the precordial lead R wave progression correlate with the position of the cardiac mass. It means where there is more cardiac mass, R wave will be prominent. If we see what happens in levocardia, there will be usual R wave progression from V1 to V6. If we see there is small r and gradually this R wave progresses towards the V6. So there is cardiac mass is more in the left side. So from this way, we can identify this is levocardia. What happens in dextrocardia? In the right-sided lead, we will get tall R, and there is regression of the R wave, and V6 we are getting small R wave. So it also denotes the cardiac mass is more in right side. So this way we can define that this is a dextrocardia. And how we can define mesocardia? In the mid precordial lead, V3, V4, we will get the tallest R, and we will get the regress in V5, V6. So in a nutshell, we can tell the cytosolitis when the P axis is normal, and inversus when their P wave is right axis. And levocardia is normal progression of the QRS from V1 to V6, and dextrocardia is non-progression of QRS. So after this situs and levocardia, we can identify the ventricular relation. There may be normal ventricular relation. There may be ventricular inversion can be present. So how to see this? This is a normal heart. The first Q wave that we are getting in the V5, V6, it is due to the septal depolarization. It is from the left side to right side. And we are getting this Q wave in V5 and V6. So this is the normal ventricular location. What happens if the ventricular is inverted? Then the septal depolarization is also inverted. So we will get this Q wave in the right-sided lead in V1. So this way we can tell not only the dextrocardia, but also can we tell the ventricular inversion that can be present isolatedly atrioventricular discordance or in corrected TGA. So this simple Q wave can tell us the ventricular inversion. So what are the clues can we get from the QRS? This is seen from the foot end of the cross-sectional from the foot end, right atrium in the anterior side. And we see that there is small R wave from V1, and there is a progression of the R wave from V1 to V3 to V6. And if we see there is a transition where the R is equiphasic to S. This is called transition. It is usually placed in the V3 level. If there is delayed depolarization, then clockwise loop, we will get in V4, V5, V6 level. But if we get early depolarization at the level of the V1, V2, then we can call it early depolarization or counterclock loop wise. This is very important because this loop helps us to diagnose or get clue to diagnose many of the congenital heart disease. In counterclockwise loop, we get the initial Q wave in lead 1 and AVL. And in clockwise loop, we get the initial Q wave in inferior leads. So we check that this is in inferior lead 2, 3 and AVF, Q wave is present. So this is clockwise loop, and most of the congenital heart disease have this clockwise loop. And what in the counterclockwise loop, there will be small Q wave in lead 1 and AVL. So what are the disease that we can get? I will discuss why this counterclockwise loop cases comes in disease during case presentation of this disease. In case of inlet VSD, endocardial cushion defect means AV canal defect or ASD, some speed atresia, some form of DORV, and some form of single ventricle. All these counterclockwise will associate with left anterior axis. So these are the acyanotic and cyanotic. I will touch a few cases. First of all, I will go left to right shunt. The most common is atrial septal defect. Atrial septal defect, we know the hemodynamics. There will be left to right shunt, and there will be chamber dilatation of the left sided. So how the ECG helps here? ECG gives the diagnosis of an ASD case, then it will help to classify the ASD, what variety of ASD is secundum, primum, sinus venous Asd, or coronary sinus type. Or it also helps the severity or magnitude of the shunt, how much shunt is there, more than significant shunt, or is this patient is going to irreversible change. That means the pulmonary pressure is going more and more, and then it becomes irreversible change. So all this we can get the information from the ECG. If we look, that RS pattern is the indicator of the RB right bundle branch block, and we get this in right-sided lead. Why we get this? This terminal R wave that is due to RVOT dilatation, where there is delayed depolarization of the RVOT. So this terminal force, if it is more, then it will show that the magnitude of the shunt is more. And if we see the ASD secondum, the axis will be, P-axis will be normal with RSR pattern, or sometimes right axis with RBB. But what happened in ASD primum? We know this primum part is developed from the endocardial cushion part. So what happened from the sinus node to AV node, then bundle of his, then bifurcating into left and right, and left also left anterior fascicle and posterior fascicle. So when there is a deficiency of this endocardial cushion part or ASD primum part, then what happens, the left anterior fascicle will be blocked or maldevelopment, so that we get left axis in ASD primum. And in this case, we know that I just mentioned that in endocardial cushion defect, we get that counterclockwise loop. So that we will get left axis with counterclockwise loop. And what happened in sinus venous ASD? It is the deficiency between the sinus venous part of the intra-atrial septum. So what might be, usually it's present with normal P-axis, but sometimes the sinus node may be maldeveloped. It can be placed anywhere, but it can go towards the AV node. So it atrial P-axis can be abnormal in sinus venous ASD, or it can be short peer interval due to maldisposition of this sinus node. So this is a 12-month male child having a clinical feature of wide and fixed beat second heart sound with a typical pulmonary flow murmur. If we see here the axis in lead 1 and AVF, this is a normal axis. If we see RSR pattern in V1, and this is a normal wall, and lead 2, 3, we get the clockwise loop. So this is a clean cut ASD secondum. And this is a 4-year child with wide same feature with the ASD feature. If we see this lead 1 is positive, AVF is negative. So here the axis is left axis. And if we see the lead 1 and AVL, these are the small Q wave. It denotes that it is counterclockwise loop. So we found that in endocardial cushion, there will be counterclockwise loop. And if we see the P wave is normal. So axis is normal in P axis, and RBB is present. So these features denotes ASD primer. And this is a 3-year asymptomatic child with ASD having normal axis. And if we see the P axis here, this is flattening or slightly upward. And if we see the P wave in the AVF, that is negative. It is unusual because sinus node, if it is normally located in inferior lead, it will be positive. So axis is abnormal. So we know almost in this time that abnormal P axis, and if we see here, PR interval is also a little bit short. So this abnormal P axis, short PR and clockwise loop with QR pattern is diagnosed as sinus venous type of ASD. So now we can classify. Now, if we look this case, 1-year male child with ejection systolic murmur, and echo showed a large ASD, 12 millimeter for 1-year child is very much large. If we see the axis, lead 1 negative, ABF positive. So this is a right axis deviation. And if you see the P wave, here P is also normal. If we see the V1, this is very important. This QRS pattern is changing now. This is monophasic R with strain pattern. So it indicates that we have to tell this patient that we have to go early surgery for this patient. This is very rare. Only 5% of patient that we have to close before 3 to 4 years when we get this monophasic R wave. So it from ECG, we can say this is a large ASD where there is more than 2:1 shunt. And this is very important sign for the ASD, croquetage sign. This croquetage sign is the a broken needle where a female needs the wear, and we get this inferior lead, this broken needle sign. If we get this in lead 2, 3 and AVF, it indicates that also there is a large ASD. And there ASD patient with severe pulmonary hypertension, age is 32. If we see the axis, there is axis is rightward, and P, if we see, there is normal P axis. If we see that P here, P is tall, so right atrial enlargement. Now, if we carefully look the QRS morphology, this QR pattern at RV strain is present. So this indicate normal axis, right axis, tall P, clockwise loop, and QR pattern. This QR pattern with RVH pattern indicate that unless otherwise, these ASD with severe pulmonary hypertension, we can label it is most probably inoperable. We must correlate our clinical findings with the chest X-ray, echo, all these things. But here, if ECG we get this, we can tell that ASD, which is most probably inoperable. So in ECG, ASD secondum, we get normal axis or right axis with RBB, and Crochet's sign is the large ASD. PR prolong can be present. And in primum ASD, along with the RBB, there will be left axis deviation, rather right axis. And here we will get the counterclockwise loop. And we can get LV forces if there is, we know in ASD primum, there is cleft lip can be present or prolapse of the mitral valve can present. For that reason, we can get LV forces also. And in sinus venous ASD, usually normal p-axis, but we can get abnormal p-axis with RBB with right axis deviation. So this also helps us to see the pulmonary hypertension, how it is progresses. If this is a small shunt, this is a terminal long R wave, large shunt. If monophasic R with strain pattern, severe pulmonary hypertension. If QR pattern with strain pattern, this indicate inoperable case. So after ASD, we see that VSD. Also, this also helps to diagnose the VSD, classify the VSD, and also the severity of the pulmonary hypertension. We know all cases of VSD usually normal axis with LV forces. We get LV forces when there is significant shunt. Otherwise, in small VSD, we will get normal like ECG. But how to classify this inlet VSD? What happens? This part is also developed from the endocardial cushion part. Endocardial cushion gives the ASD primum and the inlet VSD. So here we also get, there will be left anterior fascicle will be blocked. So we will get the left axis along with we will get counterclockwise loop like ASD primum. So let's check in a 6-month patient who having the symptom with feeding difficulty and respiratory difficulty. If we see the axis here, this is normal axis. And if we see the V1, the R and S is equiphasic, it indicates both LV and RV is large. And in V6 also we are getting tall R. This is called catch-Wachtel phenomenon. Like Crochet's sign, catch-Wachtel phenomenon also give the impression that this is a large VSD where there is a significant shunt. So with this normal axis, left atrial enlargement and clockwise loop and with biventricular forces, we can diagnose this case with large VSD with significant pulmonary hypertension. This is a 1-year child having symptom. And if we see here, the Q wave is present in lead 1 and AVL. So it indicates this is counterclockwise loop. And if we see there is also LV forces and there is Q present in the V6, so there is volume overload. So there is significant shunt. And if we see counterclockwise, that is evident inlet extension. So this VSD, if we getting pedimembranous VSD, we have to think in echo that we are missing the inlet extension. So from ECG also we can tell that this is a inlet VSD. And this is a 10-year male who was previously symptomatic, but now became asymptomatic. This is a clue for us that this patient is going to in a pulmonary obstructive disease. And if we see the axis here, this is a right axis deviation. And if we see the P is tall, that means right atrium is enlarged. So with this VSD patient, we are getting right atrium enlargement. And if we see the V1 taller and V6, it will see that the LV forces is becoming almost normal and there is no Q wave. So right axis with tall P with clockwise loop with RV strain in V1 and normal LV forces with no Q wave in V5, V6, it indicates that large VSD with severe pulmonary hypertension, most probably inoperable. So in post-tricuspid shunt, QRS is normal or rightward. If leftward, it indicates endocardial cushion defect or inlet extension of VSD. In older children with right axis deviation with RV strain suggestive of pulmonary obstructive vascular disease, if LV forces correlate with the degree of pulmonary blood flow. If the pulmonary pressure normal, LV forces will be normal. If pulmonary pressure is increasing and LLV is dilated and significant shunt, LV forces will be more, and we will get Q wave in the V5 and V6. And increased pulmonary vascular obstructive disease or Frank-Weissenmenger syndrome will have normal LV forces. I'm not discussing the PDA because it is almost like the VSD. So I'm going a very important case, and the dilated cardiomyopathy in a children, we have to look two things. One is tachycardia-induced dilated cardiomyopathy. Another is L-kappa. If we see, this is a 4-month with a symptomatic child referred to as from after diagnosing the dilated cardiomyopathy by echocardiography. If we see the ECG, in 4-month child, usually the axis will be rightward, but here we are getting the axis is normal axis. And if we see lead 1 and AV1, there is Q wave. And if we see that Q will indicate that there is lateral ischemia present with this child. And if we see the V6 and lead 1, AVL and V6, there will be ST depression that indicate there is lateral wall ischemia. And if we see the V1 also, there is no RV dominance, but in case of 4-month, it should be RV dominance, but it is not present here. And here is LV dominance. So these things also give us a clue that it must be the coronary anomaly. It probably the L-kappa, which is arising from the pulmonary artery. So this is this. I will not discuss the tachycardia-induced cardiomyopathy because it was extensively discussed in previous session. But when we are getting a dilated cardiomyopathy and we are not doing a ECG and we are ignoring these things, that will be a crime because both of these are treatable cause. And we have operated this child and he can get a normal life. So please, I will request every patient to see dilated cardiomyopathy with ECG. And the cyanotic, I will not touch every point. In tetralogy follow, this is a common where RV hypertrophy and pulmonary stenosis, there will be less amount of LV flow. If we see this a 2-month child having saturation, desaturation 72% and having the single second heart sound with white chest, ejection systolic murmur. If we see the axis is rightward, if we see there will be clockwise loop, lead 2 through AVL, and the RVH is there. In this 2-month, there is long R with a strain pattern. And these are the indicator that right axis with RVH is a point for tetralogy fellow. But what is this importance? That sudden transition. There is deepening of this R wave, and there is prominent S wave. This happens sometimes. There is a thinning of the RV wall, so we are getting this deepening and getting this sudden transition. This is not a sensitive, not a specific point, but when we get these things, we are happy. And this is the point that we level at a tetralogy fellow along with right axis deviation and RVH. So this is a case of tetralogy fellow. If we see now a 12-month where there is severe cyanosis, 56%. So clinically we can tell that this is a severe TOF. So how a ECG can tell us this is a severe TOF? There is axis is right axis, and if we see P is tall, and there is RVH present, but how the severity of TOF happens, if we see the hemodynamics, it depends on the severity of the RVOT obstruction. The more RVOT obstruction, the less amount of pulmonary will go from RV to PA. So less amount of blood is coming to LA to LV. So these LA, LV will be small. So if we see the LV forces here, this is not a significant LV forces. So here we can label this as a tetralogy fellow with small LV forces, which is a severe TOF. From ECG, we can identify these things. But here in a 12 years old who has a good saturation, 87% with single second sound with ejection systolic murmur, how this clinically we can tell that it is a milder form of TOF, or some abnormal connection is there from aorta to PA, where the LA is getting more supply. So that the PA saturation is increased. So if we see the ECG here, then we will find there is a QR pattern, RVH pattern, and also we find that the V6 is prominent here. So LV forces is good. So it is an indicator that this patient of tough pulmonary is getting supplying from the MACTA that is arising from the aorta to pulmonary collateral. So LV forces is good. And next, the 1 month sinus child who having child with single second sound with ejection systolic murmur in the pulmonary area. If we see, there is Q pattern in lead 1 and AVA. So there is counterclockwise loop and patient is sinused. And axis, if we see, this is a left axis deviation. And if we see, P is tall. And if we see, the R wave is not prominent. So 1 month child with RV is not prominent and LV is prominent. So there is LV forces. So we can think about where the right atrium is enlarged, LV is enlarged, RV is rudimentary, and there is counterclockwise loop with left axis. This is a good indicator. In a tricuspid atresia, there will be left axis deviation, right atrium will be enlarged, and there will be LV enlarged and RV is small. So this is a diagnosis of tricuspid atresia. And now this is a 6-week child with mild respiratory distress and feeding difficulty. If we see here, the axis is here, ABF is negative and left lead 1 is positive. So it is leftward. And if we see, there is also Q wave in lead 1 and AVL. So there is also counterclockwise loop. And with a left axis, we can indicate that there might be in endocardial cushion defect. If we see the here, V1, there is RV is prominent. V6, there is both LV is dominant. So there is biventricular forces. That cannot be a true ASD primum or inlet VSD. This is more complex. It can be common AV canal defect. So this is another case 12-year female with mild cyanosis with dyspnea on exertion. And this, if we see, the P is tall, that indicate right atrium is enlarged. And if we see, there is Bezier shape of QRS complex. So this Himalayan P and wide Bezier RBB can indicate Epstein anomaly, because in Epstein anomaly, the right atrium atrialized portion, this is hugely dilated. And due to RV is small, but there will be RVOT dilatation or any these causes can cause Bezier shape of RSR pattern can be present with AV block also. So right axis deviation with RVH and V1 to V2, sudden transition, most probably top. Left axis deviation with counterclockwise loop, endocardial cushion defect or tricuspid atresia. AV block can denote that endocardial cushion defect or corrected TGA or Epstein anomaly. And Q in V1 and absence of the Q in V5, V6 can tell us this complex disease corrected TGA. And pre-excitation seen in Epstein anomaly, tricuspid atresia, and corrected TGA. So take-home message is, ECG is useful in identifying situs and cardiac position. It is diagnostic in certain condition like tricuspid atresia, endocardial cushion defect, and aids in assessing the volume or pressure overload in shunt and other valvular lesion. And L-kappa and tachycardiomyopathy should be ruled out in any case of dilated cardiomyopathy. Thank you all for being with me.
Thank you, Dr. Naharuma. It was a very good presentation. It showed us how we can correlate ECG with our echocardiographic parameters and with all other things. Now, may I request Dr. ABM Abdul Salam sir, Professor ABM Abdul Salam sir, to make comments on both the presentations, the arrhythmia as well as the presentation by Dr. Naharuma. Professor ABM Abdul Salam sir, please.
Thank you, Dr. Firoz. I'm really happy and I feel honored of this.
Open your video, please, Salam bhai.
Yeah.
Video.
Is it open?
Yes.
Yeah. Can you see me? Atahar bhai?
No problem. I cannot see, but please go on.
I can see you, sir. We can see you. Please.
Okay. Thank you for organizing such an wonderful webinar on ECG basic and beyond basic. So including with the inspiration from our legend, Professor Rafique Ahmed, and Professor Hafiz Bhai from USA regularly joining with us and giving a lot of information, basics to beyond. And I really enjoyed all of your session, although I was very silent. And because I am not so much expert in ECG, and although I was head of the department of NICVD, actually we are dependent on Atahar Bhai and Mohsin and finally Tushar and as well as. So that was our weak point. But the thing is, on the way, these two speakers, Dr. Rezoana Rima and Dr. Naharuma Aive Chowdhury, has presented today's congenital cases, particularly regarding ECG. I am really proud of them. Excellent presentation, both of them. A lot of good examples, a beautiful example, well illustrated and nicely showed how ECG can help in diagnosing the congenital heart disease as well as the different kind of arrhythmia, particularly tachyarrhythmia. On the points of Professor Rafique Ahmed sir, as he was telling regarding the amiodarone, actually, which I marked, Dr. Rezoana Rima's center was actually, they were overusing this amiodarone, although they were telling they were doing monitoring. But there are really some adverse effect, which we sometimes cannot detect, remain undetected. On that point, actually the IV is a small is available, and particularly in our surgical, post-surgical, any tachyarrhythmia patient, the surgeons in ICU, they are using this small one. We also used in our ICU, in NICVD, a small one, before going to amiodarone in such cases. And regarding the points of cardiomyopathy, tachyarrhythmia induced for diagnosing regarding the reference point of duration of time, we do not classify as tachycardia-induced cardiomyopathy until it is a persistent LV mass loss or LV dysfunction, even after the treatment. Actually, we labeled it as LV dysfunction. It may be transient, mostly in tachyarrhythmia induced. After controlling the rate, the ejection fraction comes down. So that on that point, it is valid that as Hafiz Bhai was telling, so before leveling cardiomyopathy, actually it was not cardiomyopathy, it was transient cardiac dysfunction, LV dysfunction related with rate. So these are few comments, and really I am proud of both the speaker, particularly Naharuma has given a beautiful examples of cases, how ECG can help the diagnosis. Recently, we have become more dependent on echo, but a clinician, particularly Naharuma and this Rezoana Rima, they understood hemodynamics very nice, better than us. We are proud of them because they understand the ECG, and so they can correlate it. So I'm really proud of it, and they will lead the nation, inshallah, in future. And this is a wonderful opportunity for me to speak some words in front of this giant legend in ECG in our Bangladesh as well as USA. So I'm thankful to you. Thank you very much, Atahar Bhai and Mohammedullah Firoz.
Thank you, sir. Thank you. I think we have got many of the panelists, and everyone has got some question or comment. Before going for further comments, may I request Dr. Manish Shrestha from Nepal? He's going to present a beautiful case for us. Dr. Manish Shrestha, please. Please share your screen.
Hello.
Yes, we can hear you. You can go on.
Okay. Thank you, the organizing committee, to letting me show my case today here in the beautiful webinar. Thank you so much for inviting me. It was very learning experience today. It's like brushing up our ECG. It's really good. So moving to my case, it's a really short case, and it's and actually I need the input from all the adult cardiologists present listening to this presentation. So this is the case of 13 years old boy with 65 kilo, with BMI of 28.7 kg per meter square. He presented in the ER of our hospital with chest pain and palpitation for the last 4 hours. So he was apparently well actually, and his chest pain and palpitation was sudden onset while having his dinner, which was moderate intensity, non-irritating, and associated with shortness of breath. So he was afebrile with fully conscious. Blood pressure was 100 by 80 millimeter of mercury with heart rate of 190 beats per minute, regular. Saturation was 97%. Other examinations were unremarkable. So this was the ECG. So everybody in the panelists may like point out what is this. This is the wide complex. Are you listening to me?
Yes, we can hear you. Please go
So
on.
so this is a wide complex ECG. Most probably it's a monomorphic VT. So what happened next was we just were planning for the DC electrical cardio version. The ECG was converted to the to this within 15 seconds, and this was the ECG after 1 minute. So I need help here now. Uh, so you can see there is the ST elevation in lead to 3 AVF with reciprocal changes in AVL. So what will you do? So this is 13 years old boy. Like had it been the 25, 30 with 40 years old, then what will you do? So we are in dilemma here. Any comment, please?
Rafique sir.
Professor Chowdhury Hassan, sir, you comment. Professor Hafiz, sir, are you with us? No.
Rafique sir.
Rafique, sir, please.
Sir, unmute, sir.
Can you go back to the first ECG, please?
Yes, sir.
And how did the patient convert? I just missed that part.
It's just spontaneous, sir. The patient came into ER with the 4 hours of chest pain and palpitation, but when we were just trying to do electrical cardioversion itself, the patient reverted. The ECG, the rhythm was reverted spontaneously to this one. We didn't do anything.
Yeah, so I mean, it is basically, you can see that it's concordant in V1 to V6. Atahar?
Yes, sir. Right, sir.
Yeah, so it's more likely VT than anything SBT with aberration. And this is the first episode?
Yes, sir. First episode. No, nothing.
Okay. And
okay. So this is due to VT. Sir, this one, is there any issue with the coronary case? Like we were just stuck there, 2, 3, and AVF. It was just the patient came around 3 months back, actually, in the COVID era.
So this is kind of localized ST elevation in the 2-3 AVF. And how old is
changes also? 13 years.
13 years old boy. This ECG was just after the conversion, Manish?
Yes, sir. Just after, within just 15 minutes, 15 seconds. This is after, actually, this is after 1 minute. Like immediately we took the ECG, right?
Yes, so this patient body weight, he is 13, but his body weight is 65 kilograms.
65, yes, he's always like 28, BMI was 28.
Yeah, but you know, I would go with the differential diagnosis. I will not jump to acute coronary syndrome with STEMI. I will not jump. I would gather more information because of given the age and unlikely. And then one of the things that I would do is, if possible, do an echo and see whether there is any significant wall motion abnormality, because this is a transmural injury pattern with the ST elevation. Any chance of pericarditis? No. And
Yes,
then
there was no rub. There was no evidence of pericarditis. So as you said, sir, we did the same. We did the rapid echo screening in the ER. So that's I was wanted to ask, will you take him to the cath lab or will you monitor? So we didn't take the patient to the cath lab. We monitored. We kept on observation as the child was very okay. He doesn't have any symptoms after the reversal, so he was doing fine.
So let me ask you one thing.
In the echo, we found this. So like it's a like subtle sign. There was no regional wall motion abnormality, but in inferior basal septum there was some changes, some echogenic changes we see in the echo.
What about
so
repeat?
Then we monitored him in the CCU. So the patient was stable, heart rate was 72 per minute, doing fine. And so on further history taking, he had a history of fever and profuse sweating 4 days back, and just took the paracetamol only, but and no other symptoms, no running nose, no sore throat, and just history of fever 4 days back.
So
and other examinations were unremarkable.
I would
and then,
also, yeah, go ahead.
Dr. Monish, please finish. Dr. Monish, probably we lost him.
Yeah, I think so.
Are you listening?
Yeah.
Yes, we can listen.
Share your screen.
You can share your screen.
Can you see my screen?
No. Yes, now we can see your screen.
Okay, so now we did some live investigations. It was all non-contributory. CPK-MB tropi was also negative, and the COVID PCR was also negative. And the detailed echo was done, and that was also unremarkable, except from some that basal septal echogenicity issue. And the Holter was also unremarkable. So what next? Any investigation do you suggest?
So I just wanted to let you know one thing. When you read the echo, and I see this all the time with the fellows, if the fellow believes that this is STEMI, the fellow reads the echo as wall motion abnormality. So you need to tell them that send me the pictures. So there is an observer bias as well. Another important thing in this case that, you know, when there is a doubt, it is always good to do a differential diagnosis and then weigh about the clinical and the overall data analysis. So one of the patients that I had, like a 19-year-old, came to us and his LDL was like 196 or something. So like almost like a familial hyperlipidemia. So you need to be careful about this. But in this case, you know, there is a concave upwards ST elevation. Regional pericarditis is not uncommon, which is sometimes can be confusing though.
Yeah, so that we see everything, like all other tests came negative, so I was just moving fast. That's the thing actually. So now we plan CT coronary angiogram to see any coronary issues, like any obstruction or any abnormal course that causes that issue. But the CT coronary was also normal. So now now we plan for cardiac MRI because the focal myocarditis is still there in our head, because even though the enzymes were negative, all other tests came in negative, but he had a history of fever, and there's a focal changes in the cardiac, that basal septum. So we want to rule out myocarditis here. So
you can, but the thing is
myocarditis, like this was the finding in the MRI. So there was edema in the myocardium, more pronounced in the anterolateral and infralateral wall. And during his stay, he was quite uneventful. There was no issue with him. He doesn't want to stay. He just wanted to go home. And due to this COVID era, all lockdown was there, so we could not send the viral markers investigations to, because we cannot do in our center in our country. Actually, we have to send them to the India. So we could not send that, and they want to go home. And patient was quite eventful, and ECG changes was also not that significant later on. So we discharged him with the possible diagnosis of viral myocarditis. Yeah.
Thank you, Dr. Manish.
Any comment?
It was a very good workout for a young patient. In fact, a viral myocarditis with the history of fever, localized increased echogenicity, this is very rational one.
So just cost effectiveness, this, you did wonderful. Many of us may not have those kind of resources. And therefore I call it like the tincture of time is one of the powerful medicine in medicine. The tincture of time. You buy time, see how the patient is doing, do a repeat EKG, enzymes negative. So you're in good shape. And usually you will be okay with minimum resources utilization. And most of these myocarditis are prognosis is excellent.
Yes.
So what would be the first investigation to do? Is it CT angiogram or CMR?
Neither. Neither. Just follow the EKG and troponin, and you have the patient in front of you. If the patient is doing well, then good. And remember, one thing I worried about, because he had this VTAC, right? So it can be giant cell myocarditis, because giant cell myocarditis present like that way. If the LV function is normal and the enzymes are normal, then you are already in the good group. But giant cell myocarditis can be protracted. That can be LV systolic dysfunction. You may need support, and then think about if the inflammatory markers are too high, then some would argue about the anti-inflammatory, immunosuppression as well. But it is difficult in this case because subsequent course was pretty much okay. One episode of VT is probably the perimyocarditis picture, and probably prognosis is good. But you did very good because you are very thorough.
Thank you, Dr. Manish. May I ask?
One question in my head is like, why there is that ST changes? Any like, if anybody can help me with that, I cannot explain that the ST segment, but it does not resolve also. Like the segment settled, but it doesn't resolve completely. And after that, he didn't came for follow up also because he stayed far from our center.
This is well known, right? The myocardial injury pattern, and that can be global, that can be localized. We see that localized is basically if you do the post-CABG ward, we see this all the time. Localized pericarditis is not uncommon in the post-CABG situation. But in the viral myocarditis, if you look at Kim from Chicago, who did all these myocarditis and MRI and then described all these inflammatory changes seen in the myocarditis, viral, post-viral, post-inflammatory, and described myocarditis very well. He has shown that it can be diffuse, it can be focal, it can be multifocal, it can be even regional. So it is not uncommon to see the regional myocardial injury pattern.
Thank you, sir. Regarding the follow-up treatment, Atahar Ali sir, do you recommend any antiarrhythmic drug, beta blocker, or any device for this patient?
I don't think so, as because if the diagnosis is viral myocarditis, we just follow up the patient and we expect that it will heal up. So I think there is no issue of the continuous antiarrhythmic drug.
Thank you, sir. Dr. Manish, you can stop sharing your screen.
Oh, sorry.
I think we'll finish our with these presentations today because we are running out of time. It's almost 11. Now, may I take some quick remarks? Dr. Arun Maski, your comments regarding to today's presentation.
Oh, we had three excellent lectures, one from by Dr. Rima and second by Naharuma. And it's very interesting because from two parts, because we are dealing with not only with the valvula, we deal with a lot of congenital cases. And by seeing ECG, not doing echo, we get a good ideas. And this is good for residents who are appearing for final exams and final, because you invariably get congenital heart disease. And these are the common questions which are asked. And Manish, you have presented a nice case. So thank you, all the presenters, and thank you, IPDI, and all the participants for wonderful discussions. It was a great discussion. Thank you.
Thank you, Professor Maski. Professor Mohsin Hussain, you are dealing with arrhythmia and pediatric cases. How frequently you deal with this pediatric arrhythmia?
Because I worked in the National Institute of Cardiovascular Disease, and there is a pediatric department, and there's a pediatric ICU. Lot of patients with arrhythmia admitted in the NICU, and they call me frequently. Most of the time we diagnose as a case of supravenous tachycardia, atrial tachycardia, or junctional tachycardia, sometimes ventricular tachycardia, idiopathic left ventricular tachycardia. So we manage them with medically, but we do not take them into cath lab for ablation. This is our lacking.
Thank you, Professor Moshi.
We have done few cases of RFA.
2 cases with the professor from the.
He wanted to donate money for buying the equipments, but the company could not afford.
Thank you, sir. Thank you very much. Before finishing, may I request Rafique sir to show us some ECG before going?
No, I think you should. It's 11 o'clock, so 2 hours. Everybody has listened very patiently. We should do it next time. But I really thank everybody, because what was done is these are real cases that were shown, and which is very, very important. I mean, book ECG is one thing, seeing real life picture is another thing. Professor Rima, I mean, that was a wonderful presentation, the beautiful ECGs. Please save them, and if you could share it with us. We should continue doing this. Pediatric EP, we need to develop in Bangladesh. It's not the lack of machine, it's the lack of man. Please remember, before you buy a car, you need a driver. So you cannot just buy a car and sit it in your house. And that's what happens in most of the third world countries. Government gives money, that means you buy what a beautiful big car, there is no road, there is no driver, you sit it at home. So I think in pediatric cardiology, as a group, you have to make a decision that you need to develop electrophysiology, and you find 2 young physicians in their 30s. Yeah, it has to be, they have to be young, so that they learn over the next 5 years and use it. And there is a huge big gap, and this includes Nepal also, in Bangladesh, and we need to collaborate. The eastern part of India, we need to collaborate amongst each other to develop these fields. Thank you.
Thank you, sir. We have got another person who works in congenital heart disease, Dr. Tawfiq Shahriar. Are you with us, Dr. Tawfiq? No.
Yes, I'm here actually.
Can you comment?
I must first apologize. Like Rima, I must admitted with COVID. Sorry, I would like to avoid video because I'm in hospital.
Okay.
No, so I really enjoyed the cases. As I now work closely with the pediatric team, we also frequently encounter or discuss regarding arrhythmias. And as has been discussed, we have a tendency of jumping to amiodarone whenever the opportunity comes. But in many instances, maybe we could come out with giving beta blockers. But as we have discussed, that injectable beta blockers are not easily available. And also metoprolol succinate is also not easily available. So we always are giving amiodarone. So this is one thing, I think, one area which we should improve ourselves on. And also, as Rafique sir has said, it is very important in our country now, as pediatric cardiology is developing as a subject, a pediatric EP also needs to be developed at the same time. Thank you.
Thank you. Dr. Navin Sheikh, you have got a question?
Thank you very much. I want to ask a question to Dr. Rafique sir. Sir, do you have any screening program in the school for those children? As because we know the pediatric age group is below 18 years, right? So in your country, whether there is any screening program, those who want to participate in competitive sports, those who have high risk factors like history of sudden cardiac death in the family, HCM, Brugada syndrome, long QT. So in this case, I think we should do their ECG, and they should not participate in the competitive sports, right?
Very interesting question. There is no mandate here, so there is no routine ECG done. But if, of course, there is family screening, that becomes part of the family screening. But nowadays, in competitive sports, they get ECG done because there has been instances of sudden death. And I'm sure, I mean, I'm talking about a country like United States. It's not the question of affordability. We desire, and also, of course, the cost of money. But I think competitive sports, they should be screened with ECG.
Sometimes during exercise also, sir, no? During exercise like intramural or intramural coronary or anomalous origin of the left coronary for the opposite sinus, sometimes during exercise also there will be ECG changes, right? So by ECG we can exclude these risk factors. We can tell them not to participate in the competitive sports.
That Hafiz can comment, but I don't think it will be practical due to stress ECG in a large group of young people. If we could start with 12-lead ECG, that can actually exclude some of the patients with arrhythmogenic propensity.
I would request you to look at this because we are running out of time. The Bethesda conference is on the sports medicine, and there was this Bethesda conference. If you look at this, just Google Bethesda conference and sports and EKGs.
Yeah. Like ERVD, epsilon wave. Yeah, there's some. We got a patient with.
And it also differs, like in Italy versus United States. There is a difference in terms of how you approach. But look at the Bethesda conference. Google it with the sports.
When I got in Singapore, then every week, once in a week, we had OPD with the school children. At that time, we had to give them certificate whether they were able to participate in the sports, competitive, not the normal, like football or like basketball, competitive sports, whether they were able to participate. We had to give them certificate. Thank you, sir.
Thank you. Thank you very much. Dr. Abdul Jamil, you have got any comment, question? Jamil bhai, please unmute.
Nothing much to say. Today's session was fully pediatric, and actually I learned many things today. And thank you.
Thank you, Dr. Jamal bhai. Now, may I request Professor Jahid Hussain, sir, to make some remarks about pediatric cardiology, pediatric.
Okay, thank you. Thank you, the organizer, for giving me the chance to say something. Actually, it's given me much pleasure to see that our pediatric cardiologist, pediatric cardiologist subject, I should say, that developing very fast in Bangladesh. Actually, in terms of treatment, intervention, also in the echo, we have developed, I think we have developed so much. But today's presentation has been very much excellent because there has been fascination to do echocardiography, diagnosis by doing echocardiography, then treat by intervention. But like the adults, every day they practice the ECG to treat the patient. But this is to some extent lacking in pediatric cardiology, though it's very much important. What Naharuma Aive excellently has shown how we can diagnose the patient only by seeing the patient or can pinpoint or indicate by seeing the ECG that what to do next. So I think all the participants have been, including myself, have been much benefited with their presentation. Also, this has also given me insight to learn ECG, pediatric ECG, more to some extent deeply for myself as well as to teach our juniors or resident. With these few words, I like to express thanks and gratitude to the organizer for arranging such excellent presentation. I have arranged some very few significant numbers of seminars, webinar by the participation of our foreign expert, but I did not look back to arrange ECG lecture or presentation. Dr. Professor Wadud, Dr. Firoz, Dr. Professor Atahar Ali, they have done this excellent job. And Professor Rafique, we have been knowing him for a long time, and his presence, Professor Hafi's presence, gave us really the pleasure and excitement to and share our knowledge. I think with this endeavor, we learn more and more, and our cardiology, pediatric cardiology, will also develop much more in Bangladesh. What Dr. Rafique has said, that we are lacking in epidemiology. I want to develop, but the person what I seeing that I am arranged money from the government to send doctors for pediatric to do pediatric research, but I have got none from my institute to go abroad. That is the sin. Way I am pursuing my junior to go for training, electrophysiology, everything for surgery. But I am not finding the, even I asked my anesthetist, there are about 60 anesthetists in my department to go for training for anesthesia, for intensive care, but I did not get none. So we have to come out of this problem. I think at this moment, fund is not a problem in Bangladesh. But we, the juniors, what Dr. Rafique has said, we have to pursue our junior to come on more on within this field, so that we can be competent in all fields of pediatric cardiology and cardiology to treat our patient efficiently and accurately. Thank you all.
Thank you, sir. Thank you, Dr. Jayadarsan, sir. Before finishing, I must thank Dr. Rezoana Rima, Dr. Naharuma, Aive Chowdhury, and Dr. Monish, and must congratulate them for their brilliant presentation. We have learned a lot from them. And now may I request Professor Atahar Ali, sir, to wrap up the session.
Thank you, Firoz. First of all, I actually distinguish faculties, particularly Rafique sir and Chowdhury Hafiz and Zahid Hussain. Really, it was a wonderful session today. And sir, I must acknowledge that I have learned many things today. It was little known to me how much important can be ECG in the pediatric group, how much interesting can be the presentation, and how much ECG can be used in the pediatric management. It was really unknown to me, sir, little known to me. Today's presentation, three presenters, that is Rima, Naharuma, and finally the Manish from the Nepal. It was really amazing, wonderful presentation. I have learned not from the ECG, also how to present the cases also from these three participants. Really, I must congratulate these three participants. Really, it was a wonderful session. I think we should make a time to learn many things from them. Really, they are fantastic. And at the end, Firoz, I am feeling some actually that is the absence of our Professor Abdul Wadud Chowdhury. He is little sick. We must pray for him so that we can see him in the next session. And actually, there are many faculties with us today, but we cannot invite them for their contribution. And really, there was another session, Firoz, that is the ECG of the week, and Professor Muqaddas Sadi was weak, but it is because of the shortage of the time, we should not do it as because Professor Chowdhury is not also here. So, Firoz, you can conclude the session and can announce the that is the next Saturday's program. Naharuma, many thanks, many thanks, and also my convey my thanks to Rima also.
Sorry, Professor Atahar, I could not
Thank you for the kind words, sir.
I could not attend last Saturday's program. Sorry for that. Okay.
Really, actually, we failed you, sir. Actually, that is we see that you are not here, but we always inspired if you are here.
Okay. Thank you so much, Professor Atahar.
Thank you, everyone.
Thank you so much.
Atahar bhai, আমার একটা request.
Sir.
জি।
যে request হচ্ছে যে can we send the like from the group send a agenda like what's and then also time, like who has how much time, because it helps. Otherwise it's difficult to achieve things in two hours.
Okay, that is also advice to the organizer that you give the time and
Firoz,
you give the time.
Firoz,
Unlimited time.
in few days, you just arrange
also
a
the
Zoom meeting so that
concentration.
we can make our program more smoothly. You can see. But all the presentations are so much interesting, we just forget about the time, really.
That's a good point.
Yes, but this, try to keep it short. You may 15-20 minutes, you can extend your time. But excessive extension makes the participant impatient. Okay, thank you.
Atahar bhai,
Salam bhai.
একটা স্পেশাল থ্যাঙ্কস এন্ড হ্যান্ডস দেওয়া উচিত সেটা ডক্টর রিমাকে, যেটা যে ফিটাল কেসটা আর কি, এটা ইন্টারভেনশনাল ইসিজি,
আনবিলিভেবল
ইসিজি উইথ ইন্টারভেনশন,
শুধু শুনেন মানে
therapeutics, interventional therapeutics with ECG.
Absolutely right. That was like a wow moment.
Yeah.
But
very
that was extraordinary. But also from the Naharuma's presentation, we did not know that is the clockwise, counterclockwise, and its application in the pediatric ECG. What really?
Atahar bhai, that talk needs with time because you can't absorb what was told.
I was afraid of that it will be type speaker participants. I was so taking a little bit time here, sir.
গত সপ্তাহে আমি খুব ভয়তে ছিলাম, আমি তা আসলে খুব বেশি ভালো বলতেও পারি নাই অ্যাবনরমাল পিডিয়াট্রিক ইসিজি, যেটা রেনুমা আজকে খুব চমৎকার ভাবে তুলে ধরছে আর কি।
থ্যাংক ইউ স্যার।
না, এর অর্থটা হলো যার কাজ তাকে করতে দেওয়া উচিত।
100
আতার ভাই বাংলায় বলে মাথা আউলায় যাওয়া।
না, ভালো, ওদের প্রেজেন্টেশন অন্যরা ইন্টারেস্টেড হবে টু কিপ রেকর্ডস এন্ড টু মেক প্রেজেন্টেশন।
আচ্ছা চৌধুরী হাফিজ ভাই, from the coming Saturday there will be case based ECG discussion এবং we must ফিরোজ তুমি এমন ভাবে প্ল্যান করো যাতে করে হাফিজ ভাইয়ের এই ইন্টারেস্টিং ইসিজি এবং রফিক স্যার ইসিজি গুলো করা যায়।
নেক্সট সেশনে আমরা চেষ্টা করব ওই দিকে কনসেন্ট্রেট করতে স্যার।
But that is not the reason I asked for time.
but we always enjoy your ECG, case based ECG, really.
Thank you, sir. Thank you.
But today's ECG was excellent from Nepal, isn't it? It was an excellent case.
Unbelievable, really. Urmila, thank you very much.
Thank you, everyone. Good night. See you next Saturday.
Good night.
Good night.
Good night. Assalamu alaikum.